Hi, this is Brian Kemp. I'm going to share with you case number 80 in the Best Way to Do Cataract Surgery series. This is a patient with a soft lens, and you're going to see very efficient and easy disassembly of the lens with double chop and cross chop. And this patient also wants a toric lens. So you're going to see, I'm going to place this lens on the axis 100, and you're going to see how I'm able to do this fairly easily and confidently with a precise placement of the lens. So I'm using a cotton tip to steady the eye and use a corneal marker to help me center and size my rhexis. You can see I have really beautiful marks on the cornea, and I'm going to be sharing a video at some point showing you how I mark the patients and how I get such clean lines. But the patient's been marked sitting upright in the holding area, of course, because there can be cyclotorsion when the patient lies down. I'm making my incisions, my paracentesis on the right side and then left side, making sure I'm flat to the iris plane so I can get a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then dispersive viscoelastic. Holding the eye with the cannula, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel into the cornea, and then dive down. This is a patient's right eye, and whenever I do a toric lens on the right eye, I make my main incision at the 180-degree axis. After I make my incision, I push some more viscoat to fill the anterior chamber, and this is going to be my puncture style rhexis. I'm going in with the teeth sideways, and then I'm going to puncture the center of the capsule, pulling downward towards me, and then I'm going to grasp the right edge of the tear and propagating it until it's about the right diameter, going around circumferentially now, trying to maintain that diameter throughout the rhexis, trying to make sure it's well centered and sized. As you can see, this is a pretty big pupil, so you want to really use that marker so that you don't oversize your rhexis in these situations. So I finish off the rhexis, burp some viscoelastic out, and this is a capsular fornix hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, decompress on the left side, point the tip down on the right side, and then very slowly but carefully starting to spin the lens. And there it goes. It spins pretty nicely there. Irrigating the surface of the eye, positioning the sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper underneath the rhexis edge contra-incisionally, placing it in the capsular fornix, pointing the phaco tip vertically subincisionally, bringing both instruments together to crush the lens in half. That's double chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, crushing it against the phaco tip. That is the cross chop. Using a little bit of vacuum and getting around the lens with the chopper, crushing it and removing and emulsifying that first quadrant, placing the chopper around the second quadrant, crushing it and then pulling it up a little bit, and then emulsifying the lens piece. Turning the second heminucleus in front of me very carefully here, placing the chopper around the lens piece, having the phaco tip deep in the bag, crushing it, sandwiching the lens, cutting it in half, lifting the third quadrant up with some vacuum, and then crushing it and emulsifying it. Placing the chopper around the fourth quadrant, crushing it, and then sandwiching it using mechanical forces to crush it even more, and then emulsifying the lens piece. Now that the endonucleus is removed, I'm very carefully removing the epinucleus, which is kind of tumbling out on its own now, and then removing the subincisional epinucleus. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. And I do all that to maintain as much chamber stability as I can. I start subincisionally, grabbing the anterior cortical material, sweeping side to side and peeling it off, sweeping side to side, carefully teasing off the cortical material from the bag. With these really wide pupils, there tend to be some zonular laxity, so it's very important that you don't accidentally grab the capsule when you're doing the cortical removal. In the process of trying to remove cortex, you might actually grab the capsular bag. Once I've gotten the cortex out, I switch to polish mode, polishing underneath the rexus edge, removing any potential lens material as well as lens epithelial cells. Polishing the posterior capsule as well, removing any fine cortical material. In the periphery there, I can see there's some fine material, so I'm going with the port down, polishing the posterior capsule in the periphery there. Polishing the posterior capsule in the subincisional area now. And once that's good, I'm going to go in with the BSS cannula, turning the INA tip away from it, going into the subincisional capsular fornix, and I'm pulsing a little bit of BSS there. You can see there's some fine lens material that is stuck in that space. So I'm just very gently pulsing, not doing it too aggressively, just to loosen it up, and then going after it with the INA handpiece. Again, that polymer tip is really just a really nice way to be able to tackle that stubborn cortical material. I'm pushing cohesive viscoelastic to fill the capsular bag, and then I use a capsule sweep to polish under the rexus edge. First on the left side, and then on the right side. I'm going to place the single piece acrylic toric lens into the capsular bag. I go in with irrigation off, activate irrigation, make sure both haptics come off the optic, go underneath the optic, tilting it, rotating it about 90 degrees, removing all the viscoelastic from within the bag and any lens material that's adherent to the posterior capsule. So again, I am at the 100-degree axis for this toric lens. That's my target. I've switched to polish mode and polish underneath the rexus edge, removing any potential lens material there. So I'm going to go to low mag again, get my axis ring. I have my 3 marks, my horizontal mark and my inferior mark. I'm able to use those 3 points to get a good idea. And I'm trying to be at 100 degrees. And luckily, I was right on 100 degrees. So go ahead and make sure all the viscoelastic is removed from the anterior chamber. I push BSS in to pulse the angle to make sure there's no viscoelastic in the angle. So by checking with the axis marker, I've noticed that it actually rotated to 110 degrees. So I'm going to use the INA handpiece to just gently nudge it a little bit clockwise towards the 100-degree axis. As I take the INA handpiece out, I'm pushing BSS and quickly try to inflate the eye so it doesn't collapse. I'm hydrating my incisions. So again, the lens really hasn't moved. Hydrating my incision, my paracentesis now. The optic has prolapsed a little bit out of the bag, and I'm going to pop the optic under the rexus edge there, making sure it's nice and centered, being very careful not to disrupt the position there. So now that it's completely in the bag, I just fill it up a little bit to physiologic pressure, and then I'm going to check the alignment one more time here. And so again, I'm lining up my 3 marks with the axis ring, and it's just a perfect position, 100 degrees. And so again, you can see I marked the patient in the pre-op area with very clean marks, and the key is to just dry the surface of the eye. Careful disassembly of the lens, and then positioning the lens, again, with active irrigation on. Once you position the lens appropriately, quickly take your instruments out, but try to keep the eye inflated and close your incisions, and a final recheck. Again, low mag helps as well. So I hope this was helpful to you, and I thank you for your attention.